Good morning and welcome to Optima Healthcare Insurance Services webinar, Carefully Managing ECRI's 2021 Top 10 Health Technology Hazards. I'm Millie Mastromati with Optima and your program moderator. I'm excited to share the program with you today. It's actually more than I anticipated when our speaker, Rob Schluth, and I were discussing the content. Not only has he included information about the top 10 health technology hazards and strategies to mitigate those hazards, but he's going to share some information, behind the scenes information about how the hazards are evaluated if we have time to do that. So before we get started, let's do a bit of housekeeping. You are muted. You can submit questions through the Q&A feature. You'll notice that the Zoom webinar platform has both the chat and the Q&A feature. I'll monitor both, but try to use that the Q&A one for your questions because it doesn't scroll and we can keep track of the questions a little bit better. And we'll address all of those at the end if they're for Rob. If they're for me, like with technology, something like that, I'll answer them as they come up. Okay, so to introduce our speaker, Rob Schluth is joining us today from ECRI. Rob is a project leader focusing on content development and program management for ECRI's device evaluation group. And during his 25 years at ECRI, Rob has contributed to hundreds of the organization's device evaluations, problem reports, and guidance articles spanning virtually all health technologies. And he currently leads the development of ECRI's annual Top 10 Health Technology Hazards. Therefore, he is our speaker today. And he does the report and manages other special initiatives. Rob, thanks so much for being with us today, and I'll let you get started.
Oh, sure thing. Thank you for inviting me. I'm happy to talk to the group. And let's go ahead and review the sort of stuff I'm going to try and go over today. I'll start by talking a little bit about ECRI and then mainly review why we put this list together each year and the kinds of topics that we consider for inclusion. And then I'll spend the bulk of the time reviewing each of the 10 topics that were on the 2021 list. I'll try and go over why we thought the topic was important and then provide some tips to help you reduce the risks of those sorts of issues occurring in your organization. As Millie mentioned, I also have some slides at the end that kind of go behind the scenes and tell about how we create the list. I don't know that we're going to have time to get to that today. I do want to focus most of the time on the topics themselves, but I did want to make sure that you had access to that information. So the slides are there if you choose to look through them later on. And then the last slide in the deck, there's some more information, some links of places you can go to find out more about the top 10 list and to access the actual report itself. All right, so with that, let's start digging in. Okay, ECRI, we're an independent, nonprofit, mission-driven organization. Our mission, you can see at the top of the slide there, is to advance effective, evidence-based healthcare globally. And there are 3 areas of focus that we have within the organization. The first there, technology decision support. We're an independent evaluator of medical products for safety and usability, and that includes capital equipment and also supplies. It includes things like analyses of pricing data, and also value analysis tools. Patient safety, we're a patient safety organization in conjunction with ISMP. That's the Institute for Safe Medication Practices. They're actually an affiliate of ECRI. And we offer a number of risk and quality management, patient safety, infection control, and medication safety services for organizations across the healthcare continuum. And finally there, with respect to evidence-based medicine, we have a variety of services that generate evidence to help healthcare leaders advance the safety, quality, and cost effectiveness of care. So in all these areas, we help healthcare organizations make evidence-based decisions. All right, so looking a little more closely at technology decision support, this is the group that I work in. We're an independent testing evaluation lab. Our medical device evaluation program has been functional for 50 years. So it started the first issue of Health Devices, which was an old monthly journal that we produced, was published in April 1971. And ever since that time, we've been working on improving the effectiveness, safety, and economy of health services. So one of the core ways we do that is testing and rating medical devices. You can see some of the pictures from the slide here are my colleagues doing some of that testing in our lab. Another key aspect of what we do, though, is the second bullet in that list, functioning as an information clearinghouse for hazards and deficiencies in medical devices. So with that process, what we do is we encourage parties, it could be healthcare workers, could be patients, could be device manufacturers, to report problems to us, problems related to medical devices. We log those reports, investigate them when warranted, and if we have information that's worth sharing with the healthcare community, we will publish them as hazard reports or other types of alerts. So our goal for doing that is to prevent those same kinds of problems from occurring in other facilities. So the top 10 hazards list grows out of that effort. We first published it 14 years ago as a way to draw attention to some of those problems that we kept seeing year in and year out. And I've actually been involved in managing that process for the past 10 years, or this is my 10th year coming up in 2021. Okay, so why we put the list together. The main motivation, like I said, is to prevent incidents that could cause harm or severely hurt a patient. One way we do that first, obviously, is just by drawing attention to these issues. So raising awareness is important. Some of these things that we talk about are what we'd call persistent hazards or known events. So they may be the type of things that come from the problem reports that we receive. But we also look into emerging issues. So these are things that we might have identified in our testing, or maybe when conducting an investigation at a facility where an incident occurred, we may learn about some things that are worth sharing with the healthcare community. But we want to do more than just raise awareness. We want to help people in the healthcare organization assure patient safety within the organization. So we developed this list to be a practical tool to help healthcare professionals set patient safety priorities and implement preventive measures. A couple of other key features of the list that I wanted to mention. One is that it's predictive and not retrospective. So what I mean by that is this list is not an accounting exercise where we just add up the most problem reports and the ones with the most are at the top of the list. Instead, it's very much judgment oriented. So we have the experts within ECRI from all of our program areas applying their judgment to suggest topics for the list and vet them all the way through the process. So we come up with a list that we think will be representative of what a lot of healthcare organizations will need to deal with in the coming year. So how you can, again, prevent problems from happening in the future. Each of the reports includes step-by-step recommendations for action. Like I said, we want it to be a practical tool. So we don't want to just say, here's a problem, good luck dealing with it. We want to give you actions that you can take to minimize the risk within your facility. And then we get to the end of the process, we release this information in a couple of different formats. One is the full report, which is available to any member of any ECRI service. So that has detailed descriptions of the problems and our long list of recommendations for minimizing risks. We also produce an executive brief version, which is kind of a one-page summary for each of the 10 topics. And that's made available to the public free of charge as a public service. Okay, so what sort of topics do we include? What's within the scope? So I mentioned it's the health technology hazards list. So everything is going to have a technology focus. And we define hazards as device or system faults, design features, or methods of use that might, under certain circumstances, place patients or users at risk. Okay, so what sort of topics do we end up with then? As I mentioned, they have a technology focus. On the right there, you can see some of our key criteria. Also, they need to be generic. What I mean by that is we're not going to include something about a problem with one specific model of medical device on this list. We do have other services like our alerts workflow service where we provide information about hazards with specific devices or recalls and things like that. But here we're going to talk about issues that could apply to, say, a whole class of devices. Also, we think the issues should be preventable. At least there should be some steps you can take to minimize the risks of it happening because we, again, want this to be a practical tool. Once we have that group of topics to consider, we then apply criteria to narrow the list down. We do that by trying to identify where we can have the greatest impact. So we use the criterion on the left there. How much harm could it do? Could it severely injure somebody? Might it occur frequently? Might the issue be widespread and affect a lot of hospitals? Could the issue be hard to identify or have a lot of downstream effects that might be hard to trace back to the original source? And the last thing there, profile, we're talking about attention, like from the media or from accrediting agencies. No healthcare organization wants to be on the front page of their local paper for hurting a patient. So if it's the sort of issue that could draw a lot of attention, that's one that we're going to consider for our list. Okay, so moving into the 2021 list. First thing to acknowledge, this list was developed at the end of 2020, the second half of the year. So obviously it was greatly affected by what we were all dealing with, the extraordinary circumstances surrounding COVID-19. So when we move through the next couple of slides, I'm going to talk a little bit more about how some of the topics fit in with that theme. But the general thing that we see reflected in some of these topics is the move from just trying to cope during the emergency to building stronger and more resilient processes. So this past year, we've all been operating in crisis mode, and everyone's focused on just what do we need to do to get the job done. And that's great, and that allowed us to get a lot of stuff done. There was a lot of really innovative thinking and a lot of workarounds, and that can be good and that can be bad from a patient safety perspective. Ultimately, we know that crisis mode is not a long-term strategy. So the next step for the healthcare community is going to be to take the lessons learned from this past year and build more resilient processes. One thing I mentioned before we get to the specific topics, we also know that not all these topics are going to apply at all healthcare facilities. We generally recommend that healthcare facilities try to find maybe 2 or 3 topics that apply to their situation, and then work on making progress on those through the year. Okay, quickly, I wanted to kind of discuss the topics broadly and kind of the categories they fall into. So this year's list includes 2 topics that I'd classify as persistent hazards. These are the kind of general areas that we've covered quite frequently on our list. So topic number 2 there deals with medication errors. That's a topic we've addressed a number of different times, actually 11 different times on the list. We've dealt with some sort of topic related to medication errors. And topic number 7 was cybersecurity. That's something 14 years ago wasn't really on anyone's radar, but it has been on our list for each of the last 7 years. Then there were 2 topics this year that I would classify as emerging hazards. One of them deals with artificial intelligence, the other one with 3D printing of patient-specific medical devices. These are topics that's the first time we're dealing with them on our list here. So these technology areas are growing, and they're things where we think healthcare facilities need to start becoming familiar with the potential patient safety issues. Okay, so the final 6 topics this year all had some kind of COVID-19 influence. Some of them were very specific to the pandemic, but others were topics that I think existed or maybe were in the background, but circumstances surrounding the pandemic brought them to the forefront, and they ended up being on our list. So number 1 there deals with emergency use authorizations. Now, EUAs are nothing new, but what is new is the scale this past year. Organizations haven't had to deal with potentially hundreds of EUA devices at the same time. So we think they need a plan for doing that. Telehealth. So programs were implemented quite rapidly this past year, but likely not with the depth of analysis that would be required to ensure that the system is set up for long-term success. So existing programs may need to be looked at and modified to ensure optimal care. Number 4, so there were a lot of shortages of N95 respirators. We've all seen stories related to that and maybe experienced it. So that prompted healthcare facilities to look for other products and from other sources. ECRI testing of some of those other products found that they didn't all adequately protect the wearer. Topic 5, consumer grade healthcare products. So they're seeing increased use in a lot of settings, but in most cases, these aren't FDA approved medical devices. So making healthcare decisions with those products may not always be the best course of action. Number 6, ultraviolet disinfection. Those technologies can be a useful supplement to normal cleaning and disinfection, but if they're not used properly, pathogens could still exist, or bystanders or users could be harmed. And then topic number 9, so one option for hospitals this past year for coping with things like PPE shortages was to take devices that would normally be used at the patient's bedside and instead operate them at some distance from the patient. And there are some use and safety issues related to that topic. Okay, so we'll start looking specifically at the 10 topics. First, a note, I apologize. A lot of these slides are jam-packed with information. I'm not going to cover it all, but I did want to make sure that you at least had access to some of these details if you have interest in these topics. I'll try and touch on each of the topics for as much as time allows, but I do encourage you to look at the full report if you have interest and want to learn a little bit more about each of the topics. So what we put at the top of this list here was complexity of managing medical devices with COVID-19 emergency use authorization. So the issue here in the last year, FDA temporarily authorized the use of hundreds of previously unapproved products or new uses for already approved products. And with that, there are a couple of things that healthcare facilities need to be aware of. One key point is that the EUA status is temporary. It can be revoked or revised at any time. And once that happens, the legal protections supporting the use of that device are terminated. So you need to be aware of that. Second is that safety and effectiveness is not guaranteed. FDA can issue an EUA if it determines that the device may be effective. So that may be effective wording is important for the specified use. And also it assesses that the benefits of the product outweigh the known and potential risks. So in some case, there could be known risks with these products, but a determination was made that because of the emergency, it is okay to use this product. So that's a lower standard than what FDA normally uses for checking safety and effectiveness. So as a result, healthcare facilities just need to be on the lookout for the fact that there could be problems with some of these devices. All right, so for all those reasons, healthcare facilities need to be prepared. They need to have a plan for how they're going to deal with this equipment. First, know what you have. You need to maintain an inventory of EUA devices so that you can easily track them down if it turns out that something has been revised or the EUA has been revoked. Also, you need to know the status of each EUA device. And the way you need to do that is by going out and looking. We recommend that you check FDA's websites daily just to see if there have been any changes. And now actually CDRH does put out a daily email, so that's a useful tool to subscribe to so that you can get that sort of information. Lately, in fact, we talked about N95s briefly. There have been a lot of processes to decontaminate those so they can be reused, even though they're single-use devices. The EUA supporting some of those methods have been revoked in recent months. And finally, you need to have a plan. So you need to know what to do when an EUA is revoked or revised or terminated. When it's terminated and you need to stop using the device, what will you do? Can you return it to the vendor for a refund maybe or some kind of credit? Will the vendor be pursuing formal clearance, in which case maybe you can hold on to the device and wait until it has approval. Once an EUA is terminated, what that means is that the use of the device is no longer supported for new patients. So if the device is being used on a current patient, it can continue, but clinical judgment does come into play there. So if the reason the EUA was revoked was because there was a serious danger with the product, you might want to determine that it's not safe to continue using that product. Okay, so a take-home point for this one is that when the health emergency ends, which can happen at any time, EUA devices revert to unapproved status. All right, topic number 2 this year. Fatal medication errors can result in drug entry fields populate after only a few letters. Okay, so I have a feeling most of us can relate to this. If you're typing out a text with your phone or typing something in a search bar, and the system shows you words that you might be looking for. And I can't tell you how many times I'm typing a text to my kids and I hit that auto suggestion and it's the wrong word and my text makes absolutely no sense. Same sort of process can exist with a lot of medication ordering, storage, and delivery systems. Clinician types in a few letters and the system suggests similar looking drug names as a convenience feature. But there is the chance that the clinician will select the wrong drug from the list. In the example there, you can see very similar looking names and you could easily grab the wrong one. Or it could be that you intended to maybe give an infusion of the drug, but instead you selected an injection and the patient ends up getting a higher dose than was expected. So this sort of technology can exist in things like your EHRs, automated dispensing cabinets, pharmacy information systems, or infusion pumps. All right, so this table here, this was put together by ISMP. These are drug selection mix-ups that were reported to that organization. I'm not going to embarrass myself by trying to read all these drug names. I'll mispronounce pretty much every one of them. But some of these actually were fatal incidents, and you can refer to ISMP's resources to learn a little bit more about those. So a key recommendation that ISMP makes is to require entry of at least 5 letters of a drug name before the search field gets populated with suggestions. When we were putting together our top 10 report, ECRI did an analysis of FDA's Orange Book, and that's their list of approved drug products. And we found that 92% of the listed drugs have the same first 3 letters of at least one other drug. But if you extend that out to 5 letters, there's only a 58% match. So you can significantly reduce the chances for an error if you employ that 5-letter format. So ISMP recommends working with the device vendors or maybe your internal IT developers to implement that configuration whenever possible. One thing I'll mention about infusion pumps, the 5-letter recommendation is not practical with most current pump models. For that, we recommend that you work towards implementing auto programming through the MR, which offers a lot of patient safety advantages for the use of infusion pumps. So the take-home point here is that ISMP reports on several incidents in which selection errors associated with the display of similar-looking drug names led to severe harm or death. All right, topic number 3, rapid adoption of telehealth technologies can leave patients and data at risk. So during the pandemic, telehealth programs were implemented very quickly. Sometimes it was a matter of days or weeks, and usage of telehealth increased dramatically. One interesting stat that I came across was in a report from the Department of Health and Human Services. So that showed that of the number of Medicare primary care visits provided through telehealth increased in February 2020, the number was less than 1%. By April, it was more than 40%. So just a massive jump in a short period of time. So telehealth is obviously here to stay, but there are risks associated with the rapid deployment of those systems. So the risks on the left, we'll talk about them in a second, but what were the circumstances that made those risks worth taking? So we did get a lot of benefit from telehealth. For one thing, it allowed us to continue providing care during stay-at-home orders. Also, it was important to help conserve PPE and protect staff from maybe unnecessary exposures to potentially COVID-infected patients. But with those benefits, there were also downsides. So there's the risk of suboptimal treatment or medical errors. An example, I was talking with one of my colleagues about the telehealth visits, and he was mentioning having his sick toddler and he's on a telehealth call and he's trying to get the squirming toddler on the scale to get an accurate weight so that the medication that was going to be prescribed could be dosed accurately. And as a parent, I could just kind of relate to all of that going on at once and how sometimes that can make it difficult to get accurate information. Also, not everybody has the same access to the resources that are needed for telehealth. So it could be digital devices, it could be Wi-Fi connectivity, or maybe even just having a private space where you can have a telehealth consult. And then there are data security issues. Rapidly deployed systems may not have robust cybersecurity protections. So the actions that have been needed have been to look at those risks and to take steps to mitigate them. And we'll talk about those on the next slide. Okay, so technologies that are adopted may not be suitable for long-term use. So when you're rolling out these systems, steps might have been skipped in your technology assessment process. We think it's a good time to go back and revisit that process and make sure that you have systems that are going to meet your needs long-term. Also, increased usage was facilitated by reimbursement and regulatory issues. So HIPAA compliance exemptions allowed technologies to be used that maybe otherwise wouldn't have been appropriate. So commercial video platforms like FaceTime, a doctor might have used that to consult with patients. Those tools may not be viable when enforcement of HIPAA compliance resumes. Also, workflow issues. The system just might not fit in well with your workflow, and that could lead to suboptimal processes, and that alone could be a reason for why you might want to migrate systems. User training is always important. During the pandemic, it's very possible that users didn't get the training that you would normally like them to have. Also, patient selection, we talked a bit ago about recognizing that not all patients are good candidates for telehealth. Some conditions aren't treated very well that way. And in other cases, just the patient may not be comfortable with the technology or have access to the devices needed to use it correctly might have functional deficits that prevents them from using a device the way it needs to be used. And then just with cybersecurity top of mind, it's appropriate to conduct a security risk assessment. So the take-home point here, while the sudden change in practice was essential to meet the needs, so it was a good thing that we got these systems up and running very quickly, doing that can create problems and challenges. So when we have the time, we should be addressing those. Topic number 4, imported N95 style masks may fail to protect healthcare workers from infectious respiratory diseases. So this topic grew out of the supply shortages of N95 respirators that we experienced here during the pandemic. NIOSH certified N95s block at least 95% of airborne particles. But shortages of those respirators prompted healthcare facilities to look for alternative suppliers and alternative devices. So KN95s are one example. Those are models that are imported from China. They're marketed as offering N95 level respiratory protection, but ECRI's testing showed that that isn't always the case. Incidentally, I should mention that the relevance of this topic is starting to wane. The supply of N95s is improving, and FDA now recommends that facilities transition away from the use of other products. Okay, so what was happening is our members were getting these imported masks and concerned about the quality of them. They might open the box and see supposedly the same model, but the 2 different models or 2 different versions look different. So they were very concerned, am I getting the level of protection that I need? So they consulted with us. We actually obtained the equipment needed to conduct NIOSH level testing of these devices and did so. And we found that 62% of the imported models that we tested failed to reach the 95% filtration efficiency that they claimed. So users of those masks could be at risk. Now, these recommendations currently may not apply because as the situation has been improving. One thing I'll note though is that if you did have these products that didn't meet the filtration efficiency requirements, it's not a total loss. Those devices still might offer more protection than a normal surgical mask or procedure mask because they generally fit pretty snugly against the face. So we have recommended that if you have those products, maybe use them where you might otherwise use a different sort of mask and reserve your N95s for the more critical procedures where someone might be exposed to COVID-19 droplets or aerosols. So here, as we mentioned, our testing showed that these products didn't always do what they claimed to do. All right, topic number 5, relying on consumer grade products can lead to inappropriate healthcare decisions. Okay, so pictured here are some of the products that might be found in someone's home, and they're starting to make their way into some healthcare settings. So the top left, that's just a finger pulse oximeter, fitness watch that can track heart rate, and on the right there, it's a chest strap that does the same thing, tracks heart rate, and it communicates with a smartphone app. You see an image of that down there on the right. And then just a simple blood pressure monitor that you could go get at your local pharmacy. One thing to be aware of, these products are great. They can be very useful when you don't have a medical device, but a lot of these are not FDA approved medical devices. And you need to be aware of that when you're using them. Okay, so factors that have been driving the increased interest in these products, they do provide some level of care when a medical device is not available. So in a patient's home, that's an obvious example. But during COVID, there were situations where some medical devices were also in short supply within hospitals. Also, PPE shortages affected the use of these devices. So there are instances where patients who need their blood glucose monitored, rather than having a nurse gown up and go in and draw blood, they could use their home device. So like the Freestyle Libre type devices that you could do like a contactless measurement of blood glucose. So these are being used in intensive care settings in place of normal medical devices. Now the trend in the use of these devices also reflects the trend more broadly in healthcare of care moving away from acute care settings. So all that brought this issue to our attention, and concerns we have are that even though these products can actually be very useful in tracking trends of the patient's condition, they may not be the best choice for diagnosing a medical condition because they weren't designed for that purpose and they have not been approved as medical devices. So inaccurate results or misinterpreted results from these products could lead to improper care decisions. So our recommendations related to this: first, don't use these in an acute care setting if you can avoid it. If a medical grade device is available, use that instead. But if it is an emergency situation and you need to use one of these devices, make sure users are trained, recognize how it functions separately from a medical device, and also that they're aware of the potential for performance differences compared to the devices they're used to using. Mentioning the blood glucose devices, ECRI did an analysis of reports that were out there and found that evidence shows that many of those products are not as accurate as a medical grade device. So if you're basing a health care decision off of those, you need to be very careful. Now, regardless of what setting you might be using these devices in, whether it's the home or healthcare, do your best to assess the device in the seller. So that could just mean looking at online reviews or something like that, but try and vet the manufacturer the best you can to make sure it's a quality device. Also, you have to consider the ability of the users, some of the things we talked about before. Will they be able to use the device appropriately and get an accurate result? Take home point here, so that the measurements or results from such products may not be sufficiently accurate or may be misleading. So just use caution when applying those results. All right, topic number 6, hasty deployment of UV disinfection devices can reduce effectiveness and increase exposure risks. All right, so the image on the right here, so that's an example of an ultraviolet disinfection tower, the type of thing that might be wheeled into a hospital room to disinfect the room. There are other forms of these devices, some handheld wands, countertop boxes that can be used to disinfect small things like phones or smaller equipment. Even systems that could be in your HVAC system to disinfect the air flowing through. With these technologies, over the past year, what we were seeing is they're being considered for use in a lot of new environments by users who don't have experience with this sort of technology. And in some cases, even the manufacturers are new to the market and they may not have experience with the sort of applications for which these devices are going to be used. So in that environment, the chances for error are high, which is why we put this on our list. Now, ECRI has tested UV disinfection devices in the past and found that they can be an effective supplement to normal cleaning and disinfection. So at the correct dose, the right wavelength of light, the right dose, UV light can inactivate a wide range of pathogens. It does that by damaging the DNA and the RNA structures to prohibit replication. But that requires that you have an adequate dose. So like I mentioned, the correct wavelength of UV light, not all wavelengths will be appropriate. Sufficient exposure time. The surface has to get enough of that light for it to take effect. Distance, obviously the light needs to be close enough to the surface to have its effect. And line of sight's an important thing. So if a surface is shadowed by a device or some other object and the light does not hit that surface will not be disinfected. So you have to think about that when you're setting these systems up. Another point is that the surface has to be cleaned of soil. These aren't devices that you can just plop your phone in or wheel it into a room and then everything's fine. You walk away and everything's fine. The device has to be cleaned of soil. What can happen is soil on the surface could actually cover the pathogens and protect them from the UV light. So then if the soil is later disturbed, the pathogens may still be active and someone could be exposed. So concerns we have, vendors that might be new to the market, you have to consider how well they know the environment of use and are they able to provide effective guidance to users. Inexperienced users, ECRI, this is even before the pandemic, we went into hospitals and observed their use of these devices and did some testing once the rooms were supposedly disinfected and did find some discrepancies and some misuse of the devices. Particularly different operators use them in different ways. So in some cases that wasn't effective in achieving the purpose that they were there for. And then also product performance. One thing to be aware of, most of these products are not regulated as medical devices. And there aren't performance standards that all these devices must adhere to. So you do have to be careful of what device you're selecting. In a hospital, there could be an issue of, if it's not a medical device, maybe it's not on the normal preventive maintenance schedule. So it might be overlooked when you're managing your devices that way. Risks to worry about, UV light can be harmful, particularly to the skin and to eyes. So if the device is not used correctly, it could cause harm to the operator or to bystanders. And then also just the risk of it not disinfecting the surface you think that it has but in fact it has not, and pathogens remain. So our primary recommendations here are that you need to do your homework. You need to assess the vendor to look at the claims that it's making about its product, and are they realistic? And are they a reliable vendor? Can they provide good guidance? You also need to learn the basics of UV disinfection. Specifically, you have to understand the conditions that are required for disinfection, like we just talked about, and make sure that your operators are aware of that as well. All right, so the take-home point, if not used properly, these devices may not deliver a high enough dose to inactivate microorganisms, so you could still have exposure risks. Topic number 7, vulnerabilities in third-party software components present cybersecurity challenges. All right, so the issue here, a lot of medical devices include software, obviously. Some of that might be proprietary, that the manufacturer of the medical device had designed and incorporated into their device. But sometimes they use third-party software, just off the shelf. It could be an operating system like Windows or some other software component that exists in all kinds of technologies, and they incorporate it into their medical device. The trick is it's not always easy to tell when that kind of software is being used in a medical device. Like in my case, I'm looking at my laptop here. I know it runs the Windows operating system, but the medical device doesn't have a screen or may not use an operating system in that same manner, so I may not be aware of what's inside that black box. So when you learn about a software vulnerability, the first challenge is figuring out which of your medical devices could be affected by that vulnerability. And that's before you even get to the challenges related to getting a fix and then applying it in a healthcare setting, which we'll talk about in a second. Another factor that comes into play here is that some medical devices have a very long lifespan. They might be usable for 10 or 20 years, whereas some of these software components don't tend to last that long, and eventually they go out of support. So there I got an image of Windows XP from however many decades ago that was. For the longest time, medical devices might have been based off of that system. Microsoft is no longer supporting it, so those sorts of devices could maybe be at risk of malware. All right, so let's look at what are the risks. So if a software vulnerability is not remedied, there are 3 types of things that we're worried about. So first, it could compromise the medical device. So it could cause the device to malfunction in some way, or just make it not available when you need it to treat a patient. So that's going to degrade your ability to care for the patient. Second, it could trigger a system-wide security incident. So here, think about like ransomware. So some sort of malware that gets into the system that could degrade patient care and could have significant effects. It could totally disrupt operations of the healthcare system. I mean, we're seeing reports, things with the Colonial Pipeline and other sorts of attacks like that. When they affect healthcare systems, they can be devastating to your operations. And the third, it could lead to a data breach. So the compromise of protected health information is always going to be a concern. Now, an interesting thing about this topic is the third-party software within medical devices actually could provide kind of an unintended avenue to attack a health system. Say a hacker has no intention of targeting hospitals, but if the attack does affect commercial off-the-shelf software, if that software is within a medical device and that device is exposed to the malware and it's connected to your network, and then it could pass on the infection to other assets and be a risk. So whenever there's a software vulnerability, you want to do what you can to remediate the problem, but that's where a lot of the difficult challenges come in. So we've already talked about how hard it is to just know if your medical devices have software that's affected. Another challenge is what the vendor has to deal with. So a manufacturer that has to first audit its product line to figure out, okay, which of our products include the software that has a vulnerability. Then when a patch is available, they need to validate that to make sure that the patch, the fix, doesn't end up causing some sort of problems in how the medical device functions. And then they need to develop recommendations that hospitals can use when they're implementing the fix. So all that takes time and can lead to some delays. And that's before you even get it to the hospital. So the hospital gets the patch or other fix. Then they have the challenge of applying that in a clinical environment. So you could have a device that's in continuous patient use. So you're going to have issues there. Or it could be the fix that requires that you go and physically work with each device as opposed to applying it centrally somehow. So say you needed to go to all your infusion pumps, you could have thousands of infusion pumps in your facility. So obviously you can think of the resources that would be required to go and do that and to apply the fix. So these sorts of things do take time. Our recommendations then focus on trying to get a handle on what software is included in your medical devices. So part of that is going to be assessing what the manufacturer can provide. So the manufacturer disclosure statement for medical device security, the MDS squared form, that's a standardized form that provides a lot of useful information that a healthcare organization needs to know what it's going to be dealing with medical devices. Things like, does the device store PHI, or does it connect to the network? That affects how those devices are managed within your facility. The second bullet listed under number 1 there, the ingredients list of software components. So SBOMs, software bills of materials. These are a recent development and a very positive development. Medical device manufacturers are starting to produce these SBOMs that list out the various software components in their products so that a then healthcare facility can track that information a little bit better when there are vulnerabilities reported. Second aspect of it is just how you, the healthcare facility, manage that kind of information. So you need an appropriate inventory management system where you're storing stuff like software versions and things like that so that you can retrieve the devices that are potentially affected by some kind of vulnerability. So the take-home point, software vulnerability that is not remedied could allow a medical device to be compromised, and that could disrupt patient care or lead to a data breach. Topic number 8, artificial intelligence applications for diagnostic imaging may misrepresent certain patient populations. Okay, so AI is making an impact in healthcare and particularly in diagnostic imaging. For example, AI image interpretation applications have been used to help distinguish COVID-19 related lesions from other lung pathologies. And that's just one example of how that sort of software can function. AI also shows promise in a lot of other areas, specifically related to diagnostic imaging. It could speed the interpretation of studies, could help detect abnormalities that maybe would be difficult to observe with the human eye. Even has the possibility to reduce dose to the patient by allowing more efficient selection of parameters, or just by reducing the need for repeat studies. What do you need to require to get those advancements? You need data, you need good, high quality data, and you need a lot of it. So the quality output from these AI applications very much depends on the quality of the input. So the data quality considerations, main one to think about here is that inherent bias toward populations that look like those used to train the AI application. So the data that is used when you're building the application, the algorithm is going to make decisions based off of that. If the patients that you're seeing don't really, aren't well represented in that data set, you may not get optimal results for those patients. So think just a very simplistic example of data that could be based on the height and physical characteristics of adults versus, and then applying that data and assumptions from that data to children. You can get very different results by doing that. So consequences of unreliable AI functionality, if you don't understand the limitations of AI or maybe place blind trust in an application, that could lead to misdiagnosis if, and potentially inappropriate care decisions. Now, there are a lot of challenges to overcoming those obstacles. For AI developers, just getting good quality data is very difficult. They need a lot of it. It needs to be very broad-based, needs to represent all kinds of patient populations. Then there are patient privacy issues that come into play and all that. So it is a challenge for them to get good enough data. And then for healthcare providers, you need to determine how much trust you can place in the AI application. With respect to our recommendations, first, be aware that the approval framework for the use of AI is evolving. That framework affects how the algorithms can be changed over time when new data is available. So ideally, an AI application would constantly be learning. So it keeps getting new data and it gets better and better as it uses, as it gets more data on the patient population that it is being used against. However, as that process is happening, now the project is getting further and further away from what might have been originally approved. So a process needs to be implemented where systems can be updated and those updates can be checked. And FDA is working on frameworks that would allow that to happen a little bit better than it currently does. From the hospital's healthcare facilities perspective, incorporating risk-benefit assessment of AI applications in your technology procurement process, so you know what you have and you know what you're looking for. Things to do are to look at how the vendor curates the data. Does its data set represent your same patient population? How often is the data updated, and what's its process, the manufacturer's process for doing that? So the key point here is with AI applications, they depend on the data used to train them, and they can be inherently biased toward patients that look like those who were used to develop the algorithm. Topic number 9, remote operation of medical devices designed for bedside use introduces insidious risks. Okay, the images here show some solutions that were implemented during the pandemic. So that middle picture there shows an IV pole with a bunch of infusion pumps attached to it. Normally that would be right at the patient's bedside, but during the pandemic, sometimes that equipment was moved outside the patient room. One of the reasons for doing that was to conserve PPE. So if the device was in the patient's room and an alarm went off, a clinician would need to gown up, go into the room, check the device, and then come out, remove the PPE. And now you've used up a set of PPE, and with shortages, that can cause a problem. The problem is, once you move the device further away from the bedside, there could be issues with its functioning. The second image there on the right, that's a rig that was developed by engineers at Johns Hopkins. So that's the display of a ventilator, and they developed a robotic arm that from a distance, you can control that arm to interact with the touchscreen of the ventilator. So you don't need to be right there with the patient. But like I indicated, devices that were designed to be used at the bedside that are now being used remotely, there can be performance issues related to that. So it helps you conserve PPE and maybe reduce exposure to the patient, but there are risks. The key one that we point out is just reduced visual assessment. These devices were designed to be used where you're looking at the patient, you're interacting with the device, and you're doing that in conjunction. Once the device is at a distance from the patient, it's harder to do that. So you need to use extra care to make sure that you're assessing the patient appropriately. Second item listed there, delayed alarm response. A couple factors come into play here. So it could be you have a healthcare worker with the patient, the alarm goes off on the device is out in the hallway. Now you have to leave, go in the hallway, and then come back to the patient. Or you could have one caregiver in the room and then interacting with another caregiver outside the room, and you have to make sure that that functions appropriately. The third item, device performance issues. So things like the infusion pump example that we showed, there you have all the tubing running from the device into the patient. That's longer tubing than you would normally use. So that could affect things like flow rates. So for a lot of intravenous infusions, that's not going to be a big issue, but for medications that you have to very carefully titrate, that could cause a concern. So operating the device at a distance may not be appropriate in that circumstance. That also can affect alarms. So you got a longer length of tubing. So if there's an occlusion alarm, it could take longer for that information to go back to the pump and set off the alarm. And then things like tripping hazards of all those cords and the devices in hallways leading to overcrowding. So it's harder to maneuver patients around the hallway and things like that. And just the possibility of tampering, since the device is now potentially in an area where others could access it. So our recommendations are, first, this shouldn't be normal practice. So as an emergency measure, maybe we needed to do this, but we don't think it should become standard practice. And if you do need to do it, assess the risks and make sure that you have processes in place to mitigate those risks. So the slide here details some of the actions that you can take, but I'm not going to detail all of those right now. Again, the take-home point is just be aware that using these devices in a way that they weren't intended can lead to safety issues. Topic number 10, insufficient quality assurance of 3D printed patient-specific medical devices may harm patients. So 3D printing, which is also called additive manufacturing. So that's a method of creating a three-dimensional object by applying successive layers of material. It's done in a manner that the material gets fused together to form the three-dimensional object. So that technique, I mean, this is like, blows my mind compared to 20 years ago, could have ever dreamed of doing something like this, where medical devices are now specifically created for one patient. It could be something like an implant or a prosthetic. I think more commonly, it might be something like an anatomical model for surgical planning. So for heart surgery, say, they'll do CT imaging of the heart. That'll go into your 3D printing software, and they can design a model of the heart that the surgical team can then look at and plan their approach and see what they're going to be dealing with once they get into the patient. Also surgical guides for orthopedic procedures. So these are templates that help you drill in the exact correct location for what you need to do. Because these products are custom designed for the patient, the physician who's working with the patient will be pretty intimately involved in the design process, and also has to be involved in ensuring the quality of that product. So for the device to accurately represent the patient's anatomy, you need the three things on the left working in conjunction. So the design has to be clinically verified that it's appropriate for the patient. The manufacturing process has to be of appropriate quality. And then the end product has to be validated to make sure that, yes, it does actually accurately match the patient's anatomy. If that doesn't happen, you could have problems like procedure delays, surgical complications, or end up injuring the patient or causing an infection. So the keys here are to make sure that you have processes in place for, talk about two different things. First, clinical design review. So as noted, the physician plays a key role in verifying that the device matches the patient anatomy. The second thing is assessing the quality of the manufacturing process. So here you want to look at, does the manufacturer use appropriate quality processes, maybe adhering to a standard like ISO 9001. Also, does it have appropriate processes in place for how it handles materials to make sure that expired materials aren't used, or that the material has the appropriate characteristics for what you need. Maybe it needs to be flexible, or maybe it needs to be rigid. Also, can it adequately trace its products to the appropriate patient? Since this was custom designed, that product needs to make it to the patient who it was designed for. So without appropriate measures to manage the variables in the design and manufacturing process, patient care could be adversely affected. Okay, here's the summary of those listed 10 topics. And Millie, this I think is a good stopping point if there are any questions.
Okay, so we don't have any questions in the Q&A right this minute. While you were talking, I was like writing down the departments that these 10 hazards impacted. And I mean, it is a wide range throughout the entire hospital. It's, you know, I kind of like 13 departments between IT, telehealth, pharmacy, compliance. I mean, it's really interesting. So if you guys want to write in a question, you can. Just to have a quick question, and you may have covered it, Rob, that when it comes to the software vulnerability, that's scary.
Yes.
so I'm curious, what are the options for hospitals who like that the software is no longer supported and they have these you know, pumps or whatever that still work? I mean, do they just have to get rid of them, or what do you do?
It's a very tricky issue. And I'm not totally well versed in it. Now, it's the sort of thing I see all this stuff and I'm like, oh my gosh, we get, you know, get rid of these devices right away. But the practical reality, that's not going to happen. And even if, say, the device is still being supported and a manufacturer puts out a fix, say a patch, we recommend that you don't just drop everything and apply that. And I kind of would want to do that. Like I'm thinking just my home devices. Of course, I'm going to want to fix it right away to minimize the risks. But there are also dangers of doing that. You could end up harming a patient by applying a patch that affects how the device operates. So there is kind of an anxious waiting period there. So that's why being proactive on your end in terms of knowing what devices you have and what software you have, it allows you to more quickly move once you do have tools to fix things. Now, the risk of a medical device, say bringing down your network or being adversely affected from malware, I do think is small. So it's not an immediately critical need all the time. So you can afford kind of this anxious waiting period as long as you're working toward it. But in terms of software that is no longer be supported, that is a calculation that healthcare organizations need to make. Like I said, the device could have a long lifespan, and if you just purchased it, and that's another reason to think about this during your purchasing process, say. So if you're buying a device, inquire about the software that's within it, inquire about maybe the operating system, and is it nearing its end of life? If the operating, or if some of the software within that device is nearing its end of life, you could run into these sorts of issues. So maybe that's not going to be the best investment for you to make. So being proactive when you're buying devices, when you have some leverage, is going to be a good thing to do. Other than that, there can be steps you can take to minimize risk. Maybe if a device doesn't need to be connected to the network, so you have it isolated. So you can then still safely use that device because it's going to be isolated from any kind of malware attack that might attack it. So there are some things that you can do, but yeah, it is scary because it's behind the scenes, it's invisible, and you don't know what's happening when.
Okay. All right, thank you. So we don't have any questions in the Q&A and chat. We have about, let me see what time it is. We have about 4 minutes left.
Okay.
Do you want to just leave people to review the next slides, or do you want to talk about them for a second? I'm not sure how long that takes.
I can go through them pretty quickly.
Okay,
you know,
cool.
if I get to the stopping point, just jump in.
Okay.
But I'll try and do 2 or 3 minutes to go through that. Okay, so information about how we create our list each year, some facts and figures. So the first edition of the list was published in November 2007 in our Health Devices Journal. So the 2021 list was our 14th edition. Topics have covered 56 broad categories. So it's been high tech to low tech. So gamma cameras, EHRs, to casters and nuts and bolts. And I'm always fascinated by the fact, in fact, last year's list, the nuts and bolts topic was, I think, number 10 on the list. And I did a presentation. That was the one that the audience was most interested in. The low tech stuff I find very interesting. It goes to show not all problems have to be high tech. Sometimes, you know, a loose bolt causes something to crash from the ceiling, could cause significant harm. The types we covered: persistent, emerging, under the radar hazards we talked about. Most appearances on the list, so clinical alarm hazards. They've been on all 13 lists up until this past year. So this was the first year that topic was not on our list, and it's been covered in 17 different topics. Radiation exposure hazards have been covered a lot. Reprocessing and sterilization issues covered a lot. Medication errors. Up and coming topics: cybersecurity, I mentioned, has been on 7 of the last 7 lists. Now, the way we generate our topics each year. So we have this nomination process where ECRI's analysts, so this is hundreds of engineers and scientists and clinicians, use the insights they gain from just their daily work, investigating incidents, testing medical devices, reviewing the literature, talking with hospitals and medical device manufacturers. All those insights they put together and they nominate topics for us to consider. So this year we ended up with, I think it was 70 topics that we started with. So that's that number 1, that nomination process. Then we move to a triage process. We have a committee of maybe, I think it's 15 people or so, that looks at that list and narrows it down. We try to cut it down to like 15 or 20 topics we think is a manageable number that fit the scope of what we want to do and that we think are going to be most relevant. And then we put it through a voting process. So we put it out to our entire organization, both in the United States, and we have offices in Malaysia and the United Kingdom. So we do have global perspectives represented in this list. Organization votes on these topics. Then we go through our selection process. So we look at the results of that voting, and we have our selection committee. It involves, I think the number was 50 people, exactly 50 people this past year. So everyone from the CEO down to me are involved in this process of looking at the voting, discussing the results, and then from that determining what topics should be on our list. What are the 10 topics we should develop? And actually we end up selecting 11 or 12 topics and develop those so we have some sort of flexibility at the end of the process. Then we go through a refinement process. So we'll do research and start developing it. We have committees that meet, and it's kind of a thesis defense sort of thing for each of the topics, and make sure that we're covering it and hitting the right issues and have useful recommendations. From there, we go into the writing and review of the actual reports. And then at the very end of the process, we have our final ranking meeting. So this actually mirrors the selection meeting. It's the same committee, 50 people. We present each of the 10 topics and go into discussions about what the ranking should be. Some years, the list almost falls out exactly as we had it. This past year, it was very interesting discussions, very long and interesting discussions in coming up with a ranking for this past year. And then when we get to the end, we distribute it. So the end is big news. So here's a shot of Times Square promoting the existence of the list. I mentioned we produced the executive brief. So that's a one-page summary for each of the 10 topics. We do make this freely available to the public. For our members, we have a full report. So this is more like a 70-page report. So instead of 3,000 words, it's 30,000 words with detailed problem descriptions for each topic, step-by-step recommendations. So if you were addressing this issue in your hospital, look at our recommendations, and that should help you on your way. Background that provides context, and a lot of resources that you can refer to for more information. And then finally, we have our alerts workflow service. So that puts out the same information that would be in the full report, but there's also workflow tools. So the report can be assigned to someone in the facility to follow up on it. You can track the status and any responses. And there's a dashboard for administrators to keep track of things. And then here are some links to some information where you can access the executive brief for the full report. We do have a podcast that we did that we talk more in detail, more about the process sort of stuff. And you can always give us a call if you have questions.
Okay, that's great. It is quite a process, isn't it?
It's very interesting.
Yeah, it is. I don't see that we have any more questions. If somebody thinks of something and they want to email me, we can, or Rob, then we can get that taken care of. I want to thank everyone for the work you do every day. You are making a difference in healthcare, and a special happy Healthcare Risk Management Week to all of our risk managers. We appreciate everybody taking time today. We hope that you can join us for next month's webinar of Skin in the Time of COVID. And that announcement will be going out today or tomorrow. So keep your eye out for that. Thanks again, Rob.
Thanks, Millie. I appreciate it.
Okay.
And thank everyone for listening.
Yeah, I will conclude the webinar right now. Everybody have a great day.